Yeah.
So, good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. And today we are having Dr. Pinaki Mahato. He's a medical oncologist practicing in Vadodara. He has done his DM Medical Oncology and Hematology from GCRS Institute and BG Medical College, Ahmedabad. His areas of interest are various cancers like breast, lung, head and neck, and gastrointestinal and genitourinary cancers. He is currently Director of Medical Oncology, SCG Center, Vadodara, and he is also faculty for DRNB Medical Oncology Teaching Program. And we are going to have him tell us about evolution of cancer care paradigms in India. So, welcome, Dr. Pinaki. Thank you for joining us for this meeting. And you have about 40-45 minutes to talk, and we'll keep about 10 minutes for interactions. So, over to you, Dr. Pinaki. Thank you.
Thank you, sir, for that introduction. Good morning, everyone. It feels very good to come to this August Club, which has been running for so long and delivering a talk here. So, I am Pinaki, I'm a medical oncologist. I'm just sharing my slides. So, the topic that I chose is something which talks about the epidemiology of cancer as well as the science of cancer. So, we will just have a discussion about how cancer care paradigms have evolved in globally as well as in India, and just have a discussion about the state of affairs as of now. So when we talk about cancer as a global picture, it is a major societal, public health, and economical problem because it's the second leading cause of morbidity and mortality. Approximately, we see 20 million cases in 2022, and we had almost 10 million cancer-related deaths as well. And this number is only going to increase because it is estimated that it will rise to almost 35 million till 2050. Also, what is important is that the incidence of early onset cancers, that is, cancers happening in people less than 50 years, is actually increased by almost 80% in the last 3 decades. And the number of deaths is also increased by almost 30%. 1 in 5 men or women would develop cancer in a lifetime, is what is estimated, and 1 in 9 men and 1 in 12 women would die from it. So, most of us who are attending this talk, some of them would have this problem in our lifetimes. Also, what is seen is though countries which are in the high income group, basically they report the highest incidence rates. However, the deaths due to cancer are majorly reported from the low and the middle income countries. Also, it is possible that because of the disparities in the reporting, the low and the middle income countries probably are not reporting that much. And the increase in the cancer is actually going to happen mostly in these low and middle income countries, where India is actually one of the important places. If you look at the global incidence of mortality, so there is IARC and Globocan which reports these cancer incidences on a regular basis. So the last report was done in 2022, where it was seen that globally the most common cancer was lung, and closely followed by breast. And it was again the leading cause of cancer deaths, that is lung cancer. And when we look at India, we find that around 1.4 million cases seen every year and around 9 lakh deaths are seen every year. And the prevalence, 5-year prevalence is somewhere around 3.2 million. And there are reports which say that India is now becoming the cancer capital of the world. If you look at the top frequent
Dr.
cancer.
Pinaki, are you having a presentation? I mean, we are not able to see that. Have you started your PPT?
Oh, I'm sorry, is my slides
Okay.
not being
So
shared?
you need to share your screen, no,
Sorry, sir,
probably.
sorry. So you should have told me.
No, we didn't see.
I'll start again. Yeah.
No problem.
I thought I was missing something.
Yeah, no, earlier we had seen it, but then
Yeah, sorry,
we
sir.
had actually
I'll
omitted.
just,
Yeah, please.
I'll just start again, just 2 minutes.
No, it's okay. You can skip those slides.
Is my slide visible, sir?
Yes, very well.
So I was talking about the global incidences of cancer, and I was talking about the statistics. So we have the Globocan that tells us that lung cancer and closely followed by breast cancer are the most common cancers. And in India also, we see that the prevalence of cancer is also increasing. We have 1.4 million cases every year and around 9 lakh deaths every year. And if you look at the top frequent cancers, actually the most common cancer in India as of now is breast cancer, and this is closely followed by the oral cavity cancers. Previously, the oral cavity cancers were the most common, but when they are divided into different subsites, that's why the most common cancer as of now is breast. This is followed by cervical uterine cancers and then the GI cancers. If you look at the mortality, again, India contributes to almost 9 to 10% of the total mortality from cancers, and this is even more than the United States. So we are having an increased incidence of cancer. We say that almost 1 in 9 Indians are going to develop cancer in their lifetime. There is an epidemiological transition happening in India where the non-communicable diseases like diabetes, hypertension, kidney cancer, kidney disease, cancer are actually overtaking the infectious disease burden. So we are in the midst of this transition. And also we know that because of the ever-increasing detection, rapid urbanization, population aging, lifestyle changes, stress, indoor-outdoor pollution, also smoking, alcohol, physical inactivity, all these factors are contributing. So cancer has a multitude of reasons why it increases, and it is difficult to pinpoint one reason, but probably a combination of all these factors is responsible. Also, we know that medical facilities in India are still inadequate, and we have a high rate of out-of-pocket expenditure. So this probably also contributes to the to difficult management of cancer patients. This was a study that was published by Apollo Multinational Health Group in 2024, where they say that the number of cancer cases in India are going to rise at a rate which is going to surpass the global averages.
बादाम खाएगा
Also, one interesting thing that they reported that globally men actually have a higher incidence of cancer than women. That is 25% higher incidence is seen. But in India, actually, what we are seeing is more women are getting diagnosed with cancer. So this is something different that we are seeing. The median age for cancer diagnosis also in India is almost 10 years less than what we see in the Western countries. This is also very worrisome. If you look at breast cancer, the average age of diagnosis in India is around 52 years, whereas it is 63 in US and Europe. Even for lung cancer, it is almost a decade less, that is 60 versus 70. We see a lot of patients with colon cancer coming at a young age, that is less than 50 years. And despite all these trends, I mean, screening for these cancers would be very valuable. But in India, the cancer screening rates are extremely low. Like this report said that breast cancer screening in India is only 1.9% against almost 70 to 80% in Western countries, and even China is doing at almost 23%. Whereas cervical cancer screening in India is even less than 1%, where it is almost 70% in the Western nations and around 40% in China. So this remains an important health problem. And also we know that because of the meager funds, we have less spending GDP per capita on the health, and we have less physicians per population in India as compared to China or even the Western countries. We know that cancer is difficult to treat even at the most of the district level hospitals, and often the cancer patients and the families, they have to come to the big cities for the treatment. They have to sell their homes, land, and assets. So many patients, when they take treatment for cancers, actually they go into poverty, and we do not have adequate machines like radiation machines. We do not have trained technicians. We do not have many qualified oncologists or cancer nurses in India. But this picture is changing over the last decade. We are seeing a change. Our cancer patients also struggle to get palliative treatment. So a lot of patients have advanced cancers, and these patients need symptomatic control where it is difficult to get in these areas. And also at the governance level, what has happened? Though we have a national cancer control program since the 70s, what has happened is cancer has been clubbed with other non-communicable diseases like diabetes, heart disease, and stroke. And this is a common program that only gets 20% of the health expenditure, despite being the cause of almost 60% of all deaths. So though cancer is contributing to a lot of mortality, probably the investment is not that great from the government. Now, talking about the science, so what is cancer? So we know that cancer is not a single entity. There are a group of diseases involving having the abnormal increase in the number of cells with the potential to invade or spread to other parts of the body. We have almost 100 different types of cancer. We can classify cancers based on the origin as epithelial origin being carcinoma. Then there are others like myeloma, lymphoma, sarcoma, leukemia, melanoma, germ cell tumors, and you have got some mixed miscellaneous type of cancers. But what is common among all these cancers? So this was basically a very seminal paper that was published in 2000, and then this has been modified over the years, is what is known as the hallmarks of cancer. So cancer cells have some characteristics which are probably common in all the cancers. And when we talk about the mechanisms, how cancer increases, how cancer invades and metastasizes, so these are probably the common mechanisms, and it is through these mechanisms that we try to develop our drugs and try to make progress. So these are some of the hallmarks that have been noted, and these hallmarks are keep on updating day by day. When we talk about how actually cancer must have developed, so one of the popular theories is that it is kind of a atavistic thing. That is, when we say what is atavism, atavism is basically a systematic reversion to an ancestral phenotype. That means that from a multicellular organism entity, we are going towards a unicellular organism presentation, and that probably leads to the overexpression of the evolutionary older genes. And this basically rewires the architecture that links the unicellular and the multicellular gene networks. When we talk about the hallmarks, we know that most of the hallmarks that we see in the cancer cells are similar to what we see in the unicellular organisms. So that probably is responsible for why cancer happens. So it is cancer is nothing but one kind of reverse evolution, you can say, and it might be because of the activation of genes that promote growth, what we know as the proto-oncogenes, or more commonly, what we see is it is because of the inactivation of the tumor suppressor genes like BRCA and all. So these genes are normally preventing the cells from behaving abnormally, but when these genes, tumor suppressor genes, don't work properly, then we can develop the cancers. Again, there are a multitude of things that can cause cancer. It might be physical agents like ultraviolet radiation. There might be chemicals like asbestos, tobacco, aflatoxin. There might be biological carcinogens like infection from viruses like HIV, hepatitis B. So there is a list of such carcinogens, but broadly there are many things which can cause cancer, and probably it is not as simple as that exposure to one carcinogen leads to. It is probably an exposure to multiple things. Like we say in diabetes or hypertension, there are basically multiple factors involved in the development of cancer. And one of the most important factors is actually aging, because as we age, our DNA repair mechanisms become less and less effective, and that's why the errors that accumulate probably are not going to be corrected. And that is why aging is one of the most important factors that leads to cancer. Another very important hypothesis that was put forward is that probably cancers happen mostly that is because of the errors that happen during routine cell division. So spontaneous DNA replication errors are responsible for almost two-thirds of cancers. And when we say spontaneous errors, it is basically bad luck. So if somebody asks me that, sir, why I have developed cancer, probably two-thirds of those patients are having a bad luck, not rather because they have done something or they have some problem. And it was actually these people actually went and they studied the relationship between these stem cell divisions and cancer types in almost 69 cancer registries, and they found that almost 66% of cancers were because of replicative errors, that is, errors happening during routine cell division. Around 5% of cancers were because of the genetic mutations that might have happened because of the genes being transmitted from one generation to another. And around one-third of the patients actually might had some environmental reasons. So when we talk about all these three reasons, probably what we can modify is the environmental reasons. We can't modify the replicative errors, and we can't modify the genetic reasons why cancer happens. If we talk about the evolution of cancer treatment paradigms, we know that cancer treatment is not there since like ancient times. Like when we say Ayurveda, homeopathy, we don't have such treatments mentioned in our ancient texts. It is only probably since the last century that we actually understood how to treat cancer. Before that, it was basically the radical surgeries that were used to treat the cancer. And towards the turn of the early 20th century, we discovered radiation and found that radiation was also effective in certain cancers. And then after 1940s and all, we found that there are some drugs which we can use, and we developed those drugs. And then towards the end of this 20th century, we found that there are other targeted therapies, and now we talk about immunotherapy as well. So I basically deal with the systemic therapy of cancers. So I'll discuss about them in some detail. So it's an evolution from the simple modalities to the complex adaptive modalities that we are seeing in cancer care. And it is a very exciting branch to be in, because we are seeing a lot of changes that happen every 5 to 10 years. The entire treatment protocols that we are using changes a lot. So if I talk in just in brief about surgeries, when we talk about cancer surgery, we have seen a very big change in the last maybe 10 years. Wherein breast, which is the commonest cancer that we see now on a day-to-day basis, there has been a shift from mastectomy to breast conservation surgery. So when we started off in even our own center, we found that in the initial years, almost 70% of patients went for a mastectomy, but now almost 70 to 80% of patients are opting for a breast conservation surgery, wherein we just remove the involved portion of the breast and supplement with radiation. And we know that literature now says that you have an equivalent survival with breast conservation surgery vis-a-vis mastectomy. So there is no need to go for a mastectomy unless and until there are some contraindications. Also, we have seen that patients who have axillary lymph node negative radiologically can just go for a sentinel lymph node biopsy. This has again become a norm because we don't want patients developing lymphedema, and this is very safe and effective as well. Also, in certain patients where we are going for the axillary lymph node dissection, we can go for the lymphaticovenous anastomosis. So this is also something that we have started recently, and this is again to prevent that lymphedema down the line. One of the important things that we have seen in mostly all the cancers and breast in particular is that we are now opting for earlier systemic therapy, that is neoadjuvant therapy. This is basically primarily to downstage the tumors and make them amenable to less aggressive therapy, that is certain types of breast cancers like HER2 positive breast cancers and triple negative breast cancers. There is a definite advantage of doing this because depending upon the initial response that we get with the neoadjuvant therapy, we can actually divide our patients into two groups, one who respond very well and one who don't respond very well. And therefore, we can stratify the treatment based on the initial responses. Also, we have understood that cancer is more of a systemic disease. So whenever you get a patient who has a stage 1 or a stage 2 disease, at that point also, there must be cells which have already gone down into the blood and maybe settled at other sites. It is just that our scans are not that sensitive enough that we can see such cells, and therefore going for a systemic therapy initially probably will help in eradicating most of these cells and preventing metastasis down the line. So that's why systemic therapy is important, and probably it predates the local therapy in most of our patients as of now. When you talk about head and neck cancers, again a very very common entity in our country, we get patients who are mostly having the locally advanced tumors where they have difficulty in speaking or other functions, swallowing, and there is a lot of pain. So many times, what we find is surgery is not feasible at the primary stage. And here also, we have started neoadjuvant therapies, and we find that these patients do really well with neoadjuvant therapy, and we're able to preserve their facial anatomy. The cosmetology is important. Also, the function is very important when we talk about speech and swallowing. So neoadjuvant therapy also, there is some role of immunotherapy as of now also coming in this setup. We have sleep wrap reconstruction, and these reconstructions have become much better with time. We have good rehabilitation services for speech, swallowing post the treatment. This is very important because these patients, after they get cured, need to be a part of society and need to resume their social functions. Also, for the acute and the chronic toxicities, medications have become much better than before. When we talk about other surgeries, especially the cavity surgeries and the limb surgeries, we have now robots assisting us in the surgery. So robot-assisted minimally invasive surgery is something that we are using now, and this basically helps because a robot has got more dexterity than what a surgeon can operate because it has got 6 degrees of freedom, and also it leads to less operative complications and there is less hospital stay, so the patient can be discharged earlier. The cons here is that the learning curve is there, so it has to be there is a steep learning curve here, and the cost also is increased to a certain extent by doing a robot assisted surgery. We also have limb salvage surgeries for peripheral tumors. So in most of our patients who have got peripheral tumors like sarcomas, we're able to go for this limb salvage surgery along with the systemic therapy instead of going for amputation. And we always go for these neoadjuvant therapies in such patients. So even in limbs, this kind of sarcomas, we always go for some systemic therapy to downstage like radiation or chemotherapy or immunotherapy. We have some other chemotherapies that we can give intraoperatively, like in ovarian cancers. What we do is we remove the tumors and what is called a cytoreductive surgery, and then we go for something called hyperthermic intraperitoneal chemotherapy, where we infuse chemotherapy in a form of a solution at a higher temperature, that is almost 40-45 degrees Celsius, and we let it stay in the peritoneal cavity for almost a couple of hours. So that basically kills the cancer cells by local action. And all these systemic therapies, what has happened is when we go to systemic therapies in the first step, in certain patients we get such good responses that probably we don't need to go for operative strategy. So like in rectal cancer, this has become very important where many patients, we can just observe them instead of going for the aggressive surgery at the last. We can just observe them. Many of these patients might not need a surgery, where as an alternative they might have a permanent colostomy with the surgery. When we talk about chemotherapy, chemotherapy actually has evolved over the years. And initially, what we say is chemotherapy was trench warfare. That is, that we are just bombarding the city in order to kill the culprits who are staying there. So it is something which is the first generation chemotherapy, you can say. The term was coined by Ehrlich, but basically it meant about more of the bacterial treatment. But now it has become popular. This word has become popular in cancer. So there is a wide usage in various hematological and solid malignancies, but there are quite some obstacles because we have toxicities and also development of resistance eventually. So how it came about is that there was the exposure to mustard gas in the World War One and Two, and that led to lymphoid and marrow hypoplasia. This was observed, and therefore it was used to cure certain hematological neoplasms like lymphoma. Also in 1946, Sidney Farber, who was a pathologist, he actually gave folic acid to leukemia patients, and he found that the leukemia was increased, and therefore he thought that why we can't do something opposite, that is, we can make some analogs which can inhibit folate metabolism, and therefore the first cancer drug, that is aminopterin and methotrexate, was developed. By the 1960s and 70s, actually, the US government thought that let us invest in this, because they thought that it would be very possible to eradicate cancer in the next 2 decades, and therefore a lot of active cytotoxics were identified and studied. And by the 1980s, we had a lot of trials where we were combining chemotherapy with radiation as well, and then we found that combinations of chemotherapeutic agents with different actions probably work better. And this was especially seen in malignancies like lymphoma, where we had protocols like ABVD and MOP. Also, we started combining the chemotherapy with the radiation, especially in patients where we thought that surgery would lead to loss of function, like laryngeal cancers, nasopharyngeal cancers, oropharyngeal cancers, where it was difficult to go for a surgery. With the chemo radiation, we found that these were equivalent to surgery. And there were other drugs like anti-EGFR antibodies and other antibodies which came up, and that could also combine with radiation. If we talk about classical chemotherapeutic agents, so these are some of the drugs that we use on a daily basis, like platinum agents, antimetabolites, taxanes, and antifolates. So all of them have different mechanisms, and some of these mechanisms are synergistic. So like we can combine drugs which are from two groups together, and therefore we get a synergistic activity. However, we know that chemotherapy has got a lot of side effects, and that is what creates a negative feeling in the mind of the patient that they would not be able to sustain the chemotherapy. And this is something that we see in our day-to-day practice. However, I must say that what has changed over the years is the side effects of chemotherapy are now being managed in a much better way, because we have got much better medications for the side effects, and that is what has changed in the last probably 10 to 15 years. Like one of the common side effects is alopecia. So we now have a scalp pulling machine that we can apply to the scalp, and that basically prevents the hair loss. We have got better medicines for nausea, vomiting, for mucositis, for diarrhea, and other side effects. Also, we have for patients who are young, who do not have families, we also go for fertility preservations prior to going for chemotherapy. So the monitoring and the side effect medications have become much better than before, making chemotherapy much more safer and comfortable than what it was previously. But there are some conditions where it is difficult to give chemotherapy, so we should be aware of the complications like low counts, debilitated patients, advanced cancers, where probably doing chemotherapy is not an option, and probably is not important. However, there are other drugs that I'm going to discuss, like targeted therapy. So this was the next paradigm that developed in the last decade of the last century, and this is something which we talk about as precision medicine. So what is that? Is basically a cancer treatment that uses drugs to target specific molecules that are involved in the growth and spread. And this basically means that you are not involving the healthy cells. The healthy cells are unharmed. So probably this is a more precise way of than the traditional treatments, and like chemotherapy and radiation, which lead to the side effects. And there are different types of targeted therapies. You can say there are antibodies, monoclonal antibodies. So trastuzumab, that was developed in HER2-positive breast cancer, and rituximab, that was used in CD20-positive lymphoma. So this revolutionized the treatment of care and changed the standard of care. And still, after 30 years, these drugs are still our go-to drugs. We also have small molecule inhibitors, especially we know the story of imatinib in CML, which was developed by Novartis, and where CML had a survival of only 2 to 3 years. Now we have patients who are taking imatinib since last 15, 20 years also, and still surviving with a very good quality of life. Also in lung cancer, we know that most of the lung cancers, they develop because of single mutations. And therefore, we have drugs like erlotinib, which work in EGFR mutation. So again, we can ensure a good quality of life with lesser toxicity. This is the newer thing that is coming up, that is basically combining the chemotherapy with a targeted therapy via a linker. So what you basically, the advantage is here that the antibody will basically ensure that your drug gets delivered only to the cancer cell, and there the chemotherapy drug gets internalized, and therefore it acts only on those cells. So this is called as a ADC, or antibody drug conjugate, and it combines the advantages of both chemotherapy and targeted therapy. However, again, these drugs have their own side effects, so still research is going. But again, we have started using some of these drugs in our patients. So the benefits of targeted therapy, there is increased potency, fewer side effects, improved quality of life, and fewer drug interactions. However, they are only suppressive, they do not change the biology. Most of the drug cancers actually are not targetable. This is very important because people think that you have a precision medicine for every cancer, but it's not like that, because cancers have multiple mechanisms of growth and resistance. So sometimes precision medicine is not practical because you are not going to have a single mechanism by the cancer is increasing, or probably the mechanism is actually not targetable. So most of our patients will actually fall in that category. And there, the third paradigm that is developed is something called immunotherapy. So this gentleman that you can see on the left is a cancer surgeon, actually, Dr. William Cooley, and he was basically frustrated by the by the recurrence rates that he saw in his patient. That is, he used to operate on the sarcoma patients, and he saw that most of these patients developed metastasis and died, and they were very painful deaths. So he was a very astute clinician. So he actually found out that many patients who developed bacterial infections while they had these cancers got very good remissions. And that is why he developed a vaccine with two bacteria, that is Streptococcus pyogenes and Serratia marcescens. The gentleman on the right side was a guy who had a very huge sarcoma that was compressing his windpipe and his food pipe, and he was going to die in a few days. So he tried this vaccine in this patient. This patient actually got a very good response, and he lived for almost 8 years. So even in today's day and age, a patient with a metastatic sarcoma surviving 8 years is very, very miraculous. And he did this almost 100 years back, where there was no concept of actually cell-mediated humoral immunity. So he is considered to be the father of immunotherapy. But he did not understand what he was doing. So now we understand what happened probably is that the infection provoked an immune response. That immune response probably also worked against the cancer cells, and these patients got a lasting remission. So that is immunotherapy. This cancer immunity cycle is something which was discussed in 2013. That is how immune cells actually recognize and kill the cancer cells. So in all our bodies, actually, cancer cells are being made day by day. So why we are not getting cancer? Because there is a robust immune surveillance mechanism that is going inside, which is recognizing the cancer cells and killing them. And one of the important mechanisms that can be exploited here is this step where cancer cells actually are recognized by the T cells and being killed. So what they do is they do something to prevent this recognition. That is how we develop the conventional immunotherapy that we're using today. So what happens is there are some proteins that are there on the T cells which basically act as brakes or checkpoints. So if you activate those proteins, the T cell will go silent. So why is important? Because we don't want the immune system to become overactive and kill the normal cells. So they are called immune checkpoints. So what tumors do that they have developed some proteins which activate those proteins, which activate the checkpoints, and therefore the T cell does not do anything while the cancer keeps on growing. So what immunotherapy basically does is immunotherapy is also an antibody which basically blocks that checkpoint. So now the cancer cell cannot interact with the T cell, and therefore the T cell can now recognize the cancer cell as a foreign cell and therefore kill it. So we have got some immune checkpoints like PDL1 and PD1. So basically, if you block that antibody, the interaction between the cancer cell and the T cell is no longer possible. And therefore, the T cells are now able to recognize the cancer cells as being foreign and kill them. So we have different checkpoints like CTLA4, PD1, PDL1, TGT-LAG3. So this is developing day by day. And now we have a plethora of immunotherapy drugs. So these drugs first came in around 2013, 2014, and in the last 10 years, we have seen a multitude of drugs that have come up. The drugs that are seen in red here are actually ones which are available in India, and we are using them routinely. So definitely, this is something very useful. And in all these cancers that I've shown here, we can see that immunotherapy works in almost all of these cancers. But the catch in immunotherapy is that it works in 10 to 30% of patients. So it works very well in 10 to 30% of patients, but we need to identify who these patients are. We cannot use immunotherapy as a magic treatment in most of these patients. The reason being that immunotherapy is very unpredictable because our immune system is very unpredictable. We do not exactly understand how different people's immune system works. And there are some biomarkers which help us in understanding that which patients would be eligible. And these biomarkers we use routinely. But you can see here that the three biomarkers that I mentioned, that is PDL1, MSI, and TMB, these three biomarkers are actually not intersecting. That means that they might be positive. One biomarker might be positive in one patient, might not be positive in another patient, and you might have a negative biomarker and still have a response because they do not intersect each other. So doing all three biomarkers becomes costly and not feasible in all patients. What we commonly do is the PDL1, because you can see that PDL1 is the most common biomarker, but we have other biomarkers like MSI and TMB. And this MSI and TMB actually do not even depend upon the type of cancer. So FDA has given approval for immunotherapy in all cancers, whatever they might be, if they have a MSI high status or they have a TMB high status. PDL1, on the other hand, we have to look at the individual cancer because there are different guidelines for different cancers. And how we can detect this? So basically, we have got now the genomic profiling where we do analysis of the entire genome or even the genetic mutations, and therefore we can identify these patients. Genomics also has evolved in cancer in a big way because when 10 years back we were having very, very basic evolutionary, very, very basic genomics where we were doing the individual gene testing. But now we have mechanisms like NGS where we can do simultaneous gene mutations. So we do almost 500 gene mutations, 300 gene mutations, or we do the disease-specific mutation panels depending on our requirements. So genomics has now become quite cheaper, quite more available, and we are using it in a lot of our patients. One important thing is that when we know that immunotherapy does not work in each and every patient, probably it has to be combined with some other modalities. And one of the things that we have seen that chemotherapy and immunotherapy go together. So initially we thought that chemotherapy is immunosuppressive. So if you give both together, they would not function well. But what has been seen is if you give chemotherapy, chemotherapy kills the cancer cells and that leads to exposure of the cancer antigens. And this works like a fuel for the immunotherapy. So this probably helps the immunotherapy to work. So the mechanism is that when you give both together, you create an inflamed state, or you create the more release the more the cancer antigens, and then the immunotherapy can take over, and you can stop the chemotherapy maybe, and immunotherapy keeps working. So in many cancers, what we are doing is we are starting with chemo and immunotherapy, but we are stopping the chemotherapy later on, and we are letting the immunotherapy work its magic. And such combinations are not uncommon. We are using a lot of our patients like head and neck, lung cancers, stomach cancers, urothelial cancers, even in breast cancers, we have started recently using combination of chemotherapy and immunotherapy. Also, we have certain combinations of radiation with immunotherapy. So we know that when we give the radiation in the low dose, that is what we are doing in the routine patients, it is immunosuppressive. But when we give high doses radiation, it actually stimulates the immune system. So one of the combinations is giving high dose radiation and then giving immunotherapy. That also can give the responses. Also, some of the targeted therapies, like we know that VEGF is one of the important targeted therapies, which actually has an immunosuppressive effect. So when you combine a VEGF inhibitor with the immunotherapy, you get a better response. And this was classically seen in hepatocellular carcinoma because the survival of hepatocellular carcinoma we could not improve in the last 2 decades. There was no new drug which could improve the survival. And then when we combined the immunotherapy and targeted therapy, we could improve the survival by 6 months. So this was something which was very, very heartening for us. And also, we can also combine two immunotherapy drugs which have complementary mechanisms. Like we have a PD-1 and a CTLA-4 antibody. So we combine both of them. Probably we get a better immune response. However, we should be careful because they can also lead to more side effects. So there are researchers going on and combining immunotherapies with complementary mechanisms because here you can totally eliminate the chemotherapy and just go for immunotherapy. Also, the next frontier, the holy grail, what we are basically looking at is how to make those patients respond who are not responding to immunotherapy. So we must understand that all cancers we can divide into different times, and there are cancers which are hot cancers, which are inflamed cancers. So immunotherapy works very well, like kidney cancers, melanoma. On the other hand, we have cancers like pancreatic cancers, which are cold cancers, because there the immune system probably is not that much activated and the tumor microenvironment is unfavorable for their action. So how to convert the cold cancers to the hot cancers is probably the holy grail of cancer. If we are able to do this, and probably we might achieve good responses in majority of our patients. And one of the important things that is important is the gut microbiome. So we know that 90% of our immune cells actually reside in our gut. There are almost 10 to 14 bacteria there, and they're influencing our immune system and our overall health in a big way. And probably this is one of the reasons why with lifestyle changes and westernization, we are seeing an increasing incidence of cancer. Importantly, the gut microbiome is modifiable. So probably we can use this gut microbiome to improve our therapeutic response, change our treatments. And now there are labs coming up which are doing the analysis of the gut microbiome. And there are researches going on in changing the gut microbiome, like fecal transplants are being done, and people are trying to modify the responses to immunotherapy and different treatments, changing the gut microbiome. So there are some people who are called super poopers because they have got the good bacteria. So we can make the capsules from the stool and then they give it to other people. This has been used in irritable bowel syndrome and autoimmune disorders, but now recently in cancer patients also this is coming up in a big way. And another very important newer immunotherapies that we are seeing is something called CAR T cells. So what are CAR T cells? Basically, they are chimeric antigen receptors. So what we do is that in certain cancers, what we can do is we can remove the T cells from the patient and we can attach certain antibodies on them, which are called CARs. And this is specific to that particular patient because it works against that particular patient only. So we make a CAR T cell, then we amplify the CAR T cell, and then we infuse it back into the patient. And this is specifically used in certain hematological malignancies like lymphomas and leukemias, where we have CD19 directed CAR T cell therapy, and we have a BCMA directed CAR T cell therapy for myeloma. So what is seen is when you infuse it back, these CAR T cells are now like a personalized antibody, and they kill the cancer cells, and you can get the lasting remissions. And one of the striking examples of CAR T cell, this young girl actually had a refractory B cell ALL. It was estimated that she will not survive long. She had only days to weeks. And the first CAR T cell therapy was done in this patient. And after almost 10 years, you can see on the right, she is still alive. And we cannot find any cancer cells in her despite extensive testing. So CAR T cell is the next frontier, probably. But again, as I said, in certain malignancies, it will work. It will not work in all malignancies because it depends on the type of malignancy. Solid malignancies are very heterogeneous, and therefore to develop such CAR T cells for heterogeneous malignancies is difficult. And I'm happy to say that India also is now doing a good research. So people from IIT Bombay actually went to learn how to make CAR T cells, and this was made in October 2023. India's indigenous CAR T cell therapy, and this was launched in April this year. And you can see that the cost of this CAR T cell is almost 8 times less than what it costs in the US. So if commercial production has been started this year, but if it increases, then probably we can become the hub of this Indian CAR T cell therapy. And the small trials that they have done, they have shown very good responses of around 60 to 80% in certain malignancies. So this is something which is very praiseworthy. The government of India has definitely tried. We have the population-based cancer registries and hospital-based cancer registries, which meticulously record the cancer data. Recently, we have developed a national cancer grid where we are trying to collate the electronic health records of different hospitals and try to digitalize, because therefore we can get the data only then we can make the policy decisions. One of the important schemes that the government has launched is the ABPMJY, where the underprivileged sections of society, they get almost 5 to 10 lakhs of per year for the treatment. And this is basically, this started off for the cardiology, oncology, nephrology, but now many specialties like ophthalmology, orthopedics, they are also included. So many patients are getting these benefits, and we are seeing them, a lot of patients who are enrolling in these schemes. Also, there is a strengthening of the primary healthcare services from the rural areas going through clinicians, and also there are collaborations of the public and the private partnerships. Uh, Opportunistic screening for common cancers, probably screening for cancer, detecting the cancer early is the key to cancer prevention. And the government did not have definite policies because India is a very vast country. It is difficult to do the compulsory screening, what we do in the UK and the US. So opportunistic screening, it was recommended that after the age of 30, 35 years, we can do the opportunistic screening of oral cancers, breast cancers, cervical cancers. And here the role of the primary physician becomes very important because this is to be done at the level of the primary physicians. Breast self-examination is something which should be encouraged after 30 years. This can be done once a month, and this though probably does not. This probably improves the detection rates. And mammosonography, different societies have recommended different ages, but now it is being understood that after the age of 40, probably mammosonography should start, and it should be done probably once in 2 years. And after the age of 50, it can be done annually till the age of around 65 to 70 years. Pap smear HPV testing whenever possible is the key. So India had a very aggressive outlook of doing almost 70 to 80% screening of cervical cancer. However, it is not feasible, and what the most of the statistics show that only 2 to 3% of women actually get screened. Even if you look at ourselves, how many people in our own family are getting screened? So pap smear, the one of the problems that people face with pap smear is that you have to do a per vaginal examination and take a smear. So many women are not ready for this. They're reluctant to do a per vaginal examination. And there probably HPV testing would help, because HPV testing comes in the form of a kit that one can take at home by themselves and then send it back. So HPV testing, if you combine with pap smear, you can reduce the frequency of doing the pap smear, or you just don't do the pap smear, you only do the HPV testing. So these are now also coming up, and we are also telling in our patients. Colorectal screening is very important because over the world, all over the world, what is being seen is that the number of patients with young colorectal cancers is increasing a lot, and that's why the age of colorectal screening was actually after 50 years, but now people are saying that we should make it around 45 years, or even 40 years we should start the colorectal screening. Lung cancer screening again is not practical in all the population, but probably in smokers it is important after the age of 50 years, where we do the low dose CT scans. And this is also important because many patients now are coming with the early lung cancers where they are curable by surgery and other modalities. Prostate cancer screening was done very aggressively in US and UK, but it was found that it did not decrease the mortality rates. And therefore, prostate cancer screening is now something which is to be individualized and has to be discussed, because there are pros and cons of doing the screening. You might detect the early cancers which do not need to be treated actually. So that is something which to be discussed. Vaccination is important. HPV vaccine is now available. We have an Indian HPV vaccine as well. By In the Western countries, they actually do a compulsory vaccination in children after 9 to 10 years of age. But even in India, we have got queries from many people asking about the cancer vaccine, and that's why HPV vaccine is something. Even a single shot of this vaccine is almost 70 to 80% effective. So one must try to educate the patients or even the lay persons that there is a vaccine for a particular cancer, because most of the cervical cancer patients that come to us come in the stage 3 or the stage 4 where the mortality rate is quite high. If they can take this vaccine, because HPV has got a latent period of almost 20 years, so we need to take this vaccine at an early age. We cannot take this vaccine after 50 years. So HPV vaccine is important. Also, Hep B vaccine, especially in healthcare professionals, reduces the risk of developing the HCC, hepatocellular carcinoma. We do have genetic risk assessment, because when we see our patients, a lot of these patients ask, can we do a genetic risk assessment for cancers? Do I carry some genes which increase the risk of cancer? So yes, we do that. They are generally blood tests, and by them we can go for the risk reduction strategies. We can do some risk reduction surgeries like what Angelina Jolie did, or we have some medicines and we have some specific drugs also that work in particular mutations. So all this is again evolving and becoming part of the standard of care. So all the we know that these are some of the risk factors that are there, and probably one can steer clear of these risk factors. But as I said, it is not the only factor that is leading to an increased incidence of cancer. Probably pollution also, diet and lifestyle changes are very important factors that are probably leading to an increasing incidence of cancer. And whether we can prevent all these cancers from happening is a very interesting question, but difficult to answer really. We don't have the answers to that question. Or probably what we can do is go for these lifestyle changes like staying at a healthy weight, being active, taking vaccination, and avoiding the tobacco and the alcohol probably is what we can do. But as I said, two-thirds of patients probably are developing cancers due to bad luck. So it is difficult to generalize and say that these are 100% effective against preventing cancer. So the take-home message here is that number of patients from cancer are increasing. There are changes like diet, environmental, and lifestyle changes responsible. Whatever reversible factors we have, we can try to modify them. Well, most important thing that I probably feel is screening is important. So screening is something that we should all go for, because screening saves lives. The mortality from screen detected cancers is extremely low. And one of the important things in cancer, because we have so many modalities that I've discussed, the treatment of cancer should not be discussed with the individual person, but rather a multidisciplinary tumor board should take the decisions, because that always leads to a more scientific treatment and basically gives a better care to the patient as compared to an individual deciding what to do first. Because most of the specialists, what they do is when they see the patient, they do their treatment first and then they send across to the hospital. Health insurance is extremely essential. Probably health insurance is more essential than life insurance, because if you don't have a good health, then probably life is not that great. So this is just a snapshot of our multidisciplinary tumor board. So we have these MDT discussions regularly where we discuss the cases and we try to find out what should be the optimum sequence of treating these patients, and it is not an individual who decides, but rather the collective thing that we decide. And we learn a lot in these entities because as a medical oncologist, I am not trained in surgery or radiation, so I learn a lot from my colleagues how to approach a particular patient. So it helps us as it helps the patient as well. With that, I finish my lecture. Thank you all for a patient hearing. I would like to
Thank you, Dr. Pinaki. That was excellent. You may please share, stop the screen sharing. Yes. So thank you so much. It was excellent, a very elaborate, informative talk on medical oncology and how things are changing. I was wondering whether this much explosion of various new treatment modalities, does it lead to any confusion in treatment of various categories of cancer? Like somebody would offer this treatment, somebody would offer the other treatment. Does it happen, or it's the other way? You talked about tumor board.
So it happens a lot, sir. It happens a lot, and we learn from our mistakes, or you can say we learn from each other, because the concept of a tumor board is that everybody learns from each other. So the guidelines also we follow. Generally, we have the American guidelines and the European guidelines. Indian guidelines are not really there, and most of us are following those guidelines. So when if people go to, because in cancer what happens is people take opinions. It is not that people will go to a single doctor and decide that you're going to treat. So there are some differences of opinion, but most of us are on the same page. Having an MDT discussion always helps. Basically, it helps the patient, and it is also important medically, because if you have done an MDT, then you are probably safe. In court also, you can say that you have done an MDT, and I think MDT helps everyone. But we are having a plethora of changes, so we find it difficult to keep track of all the updates. And sometimes we learn of new things, and our colleague recommends something, then we say, "Oh, this has also come in this cancer." So it keeps changing, the bar keeps changing. But yes, the gold standard still don't change much. So it takes almost a decade to change the gold standards and accept what is new. But yes, we keep seeing new things in oncology. It is a young branch. Still, I would say it's a very young branch of medicine.
Right. Thank you. Any other question, comments? Jagdish bhai, yes.
Yeah. Do you practice scalp pulling routinely in chemotherapy patients?
Yeah, so we have recently acquired a scalp pulling machine, and this machine is being used since last 1 decade, and many of our colleagues are using it. So yes, it is definitely important, because what we generally use it in is mostly in breast cancer patients, because female patients, they have that fear of alopecia, and because of that alopecia, they're not able to go out socially. So scalp pulling is not perfect. That is something which tell our patient probably 70% of the hair loss can be prevented by doing the scalp pulling. But it is basically a scalp cap that has to be tied while you're taking the chemotherapy. So it is uncomfortable. It creates a feeling of intense cold over the scalp. So one has to understand the things, and the hair care also has to be taken properly. So one has to do those things. Otherwise, one will lose hair, and then people will not be happy. So scalp pulling works, but in certain patients, and we do educate those patients about the do's and don'ts before they start scalp pulling. But yes, we have seen good results in a few of our patients. Scalp pulling has really prevented damage.
Jagdish bhai, what we had seen in HCG, some of the smart ladies used to take off all their hair and make a
Wig.
wig and
Yeah.
wear it. And you all know that after the chemotherapy, the original hair regrows. So thank you, Pinaki, for a very comprehensive and brief bird eye and macro and micro vision of cancer and personalized medicine which you are offering.
Thank you, sir.
Thank you, Dr. Sant. I acknowledge your help in getting us speakers from SC. Thank you. Yes, Jagdish bhai.
There is a question in the chat box about lymphedema management. So I'm not a surgeon, but recently we have started this LVA, that is lymphatic-venous anastomosis, in prophylactically in patients. I don't know in how many patients they are doing, but yes, we have a lymphedema clinic also in our center. So we are doing the specific lymphedema exercises also to prevent the lymphedema. We know that this is a lifestyle, this is a disease that happens over time. It does not happen immediately. So So we have a lymphedema clinic as well as we are doing these surgeries. How much it will reduce the incidence, I really don't know, but I'm just seeing that we have adopted. Also, sentinel lymph node biopsy we are doing with a ICG dye, so it is a very high sensitivity and specificity. And in the patients, almost like we have crossed around 150 patients now who have done the SLNBs, and we generally find that the SLNBs these patients do not develop lymphedema, almost 2 to 5% only rate of lymphedema with the SLNB. Also, if you do an SLNB, probably the venous access on the same side probably can be used, because if you have a ALND done, then we are not using that same side for any taking any blood test or giving the infusions through that side to prevent lymphedema.
What is
True, and
incidence of
Pinaki,
cardiotoxicity?
So cardiotoxicity, the incidence is around 1 to 3%. And though we talk about it, especially when we deal with drugs like anthracyclines, we hardly see any cardiotoxicities and serious. And there might be cardiotoxicity in the way that when you do a echo, you see that the ejection fraction goes down by 10 to 15%. But mostly the patients are asymptomatic. They don't really develop the symptomatic congestive cardiac failure. With anthracyclines, there is a very low threshold of stopping the treatment, but with some drugs like trastuzumab, you have reversible cardiotoxicity, meaning that if you stop it, it is like a myocardial stunning. So if you stop it, it reverses on its own. You don't have to do anything additional. And some of these patients down the line, we can even re-challenge and give the drugs. So cardio-oncology is again evolving as a separate branch altogether. But so far, we have not had many problems with this cardiotherapy. We definitely have some cardioprotective agents as well that we can use, but prophylactic cardioprotective agents we don't use routinely. We monitor these patients very closely and generally try to avoid such drugs in patients who are susceptible to cardiotoxic drugs.
Right.
Okay. So thank you very much, Dr. Pinaki, once again. And we end the session here. We meet next Saturday morning again. Thank you all for joining. Thank you.